Welcome to the CAA 2020 Explore webinar series. Today we have Singapore's response to COVID-19 with Professor Yih Yng.
Hi, my name's David Waters and I'm the Chief Executive of the Council of Ambulance Authorities. Welcome to the last in our 2020 webinar series. Today we have the pleasure of bringing you a speaker we brought to you before. Dr. Yih Yng is from Singapore, and Yih Yng is going to speak to us again today in relation to Singapore's response to the COVID-19 pandemic. We had a lot of feedback following our previous COVID-19 webinar, particularly in relation to Yih Yng's presentation. So we thought this was an opportunity to bring Yih Yng back and have a more in-depth look at Singapore's response to COVID-19. Yih Yng is well known to us and our members. I'm sure you'll find this presentation really interesting, particularly from a strategic and infection control perspective. Yih Yng is the Home Team Chief Medical Officer for the Ministry of Home Affairs for Singapore Health. Yih Yng oversees healthcare policy for the government Homeland Security sector, and he works for the Ministry of Health in strategic development of pre-hospital emergency care services, including the community training, emergency response and technology. Yih Yng developed Singapore's first CPR and AED crowdsourcing app and implemented the world's first national residential AED program in his previous role. So please join me in welcoming back Yih Yng to close off the CAA 2020 webinar series. Yih Yng, welcome back. Nice to see you. Thank you for giving up your time, and we look forward to your presentation. Thank you.
Good afternoon. My name is Dr. Yih Yng from the Tan Tock Seng Hospital Emergency Department. I'm also the Chief Medical Officer of the Home Team of the Ministry of Home Affairs. Today I'm going to talk about Singapore's response to COVID-19, what we've done and what we've learned so far. So this is Singapore in a nutshell. We have 5.6 million people. In 2019, right, we had 19 million tourists coming in. But this year with COVID-19, right, the 200 planes of the Singapore Airlines have been grounded to the point that only 10 of the planes were flying in May. We started compulsory mask wearing since April 15th. And, I think everyone has been affected by COVID-19 one way or another. So Singapore has a DORS-CON alert level. This was something that we inherited from SARS. So DORS basically stands for Disease Outbreak Response System. So the idea that if you needed to be able to coordinate a nationwide response, that everyone could scale up immediately, you needed to have a common understanding of what a disease outbreak is like, how infectious it might be, and what are some of the implications. So since SARS, which was 2003, that's 17 years ago, we've actually come up with a disease outbreak response condition alert system. So green is when things are normal or when there's a very mild disease. Yellow is when there's limited local spread, and orange is when it is severe and there is a significant risk of spread. And red is when it is widely spread and out of control. So this is the situation as of the 5th of December. This is when I'm recording the talk. As you can see, current situation in Singapore, we have 58,000 cases total. There are 68 cases actively in the entire country for 5.6 million people. We have no cases in the ICU, and 26 cases are staying in the hospitals. 29 have died since the start of the pandemic. And as you can see, the number of cases that have been isolated, discharged, still fairly significant. There are 42 cases which are isolated in various places, and most of them are in quarantine facilities. So this is not a bad result as far as things go. And it's a result of a lot of hard work, which I'll talk about as we go along. So unless, well, if you think that Singapore is really very different from everywhere else, the answer is that's false. Just like everybody else, we're human. In the midst of the pandemic, right? This was early March, maybe, when the government was starting to announce, or there were rumors about a lockdown coming. So the shelves were cleaned out, and you can see people buying crazy amounts of rice. I think that lady in the picture there is probably hauling away about 50 kilos of rice. That's probably her entire body weight in rice. So it was nuts. I mean, even condoms were flying off the shelves, but probably not for the reason that you think. Here you go. This is one of the possible uses for some of the condoms. So, in March, this gentleman called Thomas Puyo actually wrote an article, a very, very deeply insightful article, which I would highly recommend that if you're interested in some of the coronavirus thinking, you should consider reading. He wrote this on a website called Medium. And he wrote the article. It was called The Hammer and the Dance. It's a very deeply insightful article, very data-driven. This gentleman is an engineer with an MBA. So he was writing, looking at data and looking at the situation of how the pandemic was going viral. And when he looked at it, he wrote quite a few insightful thoughts about it. And this really mirrored the strategies that we actually did take in the end. Not that he actually drove our strategies, but what he wrote mirrored very closely to what many Asian countries have done. So the idea behind the article, The Hammer and the Dance, is that the hammer would be a severe lockdown or a strict lockdown to dampen the rise of the viral pandemic. And after that, as the country starts to reopen, the country needs to look at different ways of safely opening without allowing the disease to spread quickly. So hence the idea of a dance, something that is very technical, very flexible in its approach. So he's written, I think, 7-8 articles since. A lot of them are very good articles, and I would highly recommend, if you're interested, to Google for him and the articles that he wrote about how some of the observations that he made about different countries coping with the pandemic, and what has been successful and what has been less so. So the idea behind this hammer and the dance, right? The idea is to really cut transmission very significantly. And of course, how that would happen would be with a lockdown, social distancing, that way to cut transmission very immediately. And after that, the idea of the dance, as we mentioned, is to contact trace, quarantine, isolate, educate the public for proper social distancing, and then to restrict the number of people gathering. So many measures to try to make sure that the outbreak does not rise again. So while some countries have been very successful, others less so. So I'm going to just talk a little bit more about Singapore's own experience, about how we actually initially thought we did very well. We did not have a lot of cases, but then it started to go viral very significantly, and then we had to go through the same lockdowns as well. So this is Singapore's data and our own epidemic curve. So as you can see, right, in the initial phases, we were doing really quite well. The first case actually broke in, I think, January, and we were doing fine all the way through March and maybe even up to early April. And suddenly, the cases start to just explode. And that was when we initiated the lockdown, looking at the rising numbers. But even then, when we decided on the lockdown, you can see that the cases continue to rise quite significantly all through May and June. And, as it slowly started to tail down, it took really 4 months for it to really settle down. Then after that came the very prolonged period of what they call the dance, which was really to look at measures to safely allow the economy to open, to surgically quarantine as little as possible, but yet being able to mitigate the disease. So as you can see, this is a split of the epidemic curve, right? What you can see is that the first cluster happened really quite early. This was somewhere in Jan. After that, as cases started to rise globally, a lot of Singaporeans returned. Many of them were detected as symptomatic cases. The green shows people who are detected while isolated and quarantined. So these really had no community impact. And as you can see, the second curve here shows not the imported cases, but the community cases. So community cases initially, they were quite few, and then they were all successfully contact traced. But as you can see, as we started to go towards March and April, suddenly there was an explosion of cases, especially with the returnees, that's one, causing a huge rise in the community. And then after that, with the lockdown, this started to go down. Just as we thought that we had actually succeeded, what we missed out was that there were a large number of migrant workers who live in Singapore. There's about 300,000 of them. And because they stay in close quarters in dormitories, when the outbreak started to take root in the migrant worker dormitories somewhere in April, the numbers were explosive. As you can see, right, these numbers here in terms of importations, you're looking at, a scale of up to 40, 50. Community spread about 40, 50 as well. So it's not really a lot. But when you look at the scale of this, right, dormitory residents, it went up to 1,000 a day. So it was really on an unprecedented scale where the dormitory outbreak was going at. So as you can see, this really lasted all the way until September, and it's finally sorted out, now. So the initial importation of cases, right? First case was actually 23rd of January. I think that's actually Chinese New Year. And then the first cluster that was picked up, right, was also tourists, on the 4th of February. So it was a group of tourists. I believe they were from Wuhan, and they went to a traditional Chinese medicine shop. So initially, we didn't mandate masks, and anyway, the supplies of masks were actually limited. So initially, what was advocated was that just safe distancing and mask was not actually required. But over time, right, the stance had changed. Also, we realized that it was something that really there was no way to avoid not wearing masks, and also it took some time for the supplies of masks, right, surgical masks as well as reusable masks to eventually become more available. Initially, I think there were some doubts about whether some of the reusable masks were effective. But over time, we've pivoted and we started to move away from that idea, and we've started to embrace this whole idea of mask wearing very wholeheartedly. So this was an article produced by the Straits Times. We even had academics from the Research Institute doing testings to see what kind of masks work best, and then these were all published in the Straits Times, which is our local newspaper. So as you can see, we had a very wholehearted pivot on this whole idea of wearing masks, and it's actually embraced by the population. So, Chinese New Year came and went, and this is for those of you who are Chinese or who have experienced Chinese New Year in one way or another. There were all these memes on the internet about how you would get, 2 oranges and and a thermometer, or even the red packet, which is very common during Chinese New Year, would be filled with a surgical mask, which by then became more valuable than money itself. These red packets, typically during Chinese New Year, people would actually put money in, and then they will give it to the unmarried singles as well as children. So that's a very typical Chinese New Year tradition. So with March to May, many countries started to be hit by the pandemic. And with the COVID-19 pandemic, there were a lot of issues where countries did not have enough hospital capacity, or there were concerns that healthcare would not be catered for foreigners. And as such, the Ministry of Foreign Affairs had started to advise overseas students to return. And with the drove of returning students from all over the world, we started to see outbreaks of cases coming in, and some of this went to the community as well. So the whole hammer, or what we called, we termed it as the circuit breaker, started on the 7th of April. So this lasted for about a month, where essentially businesses were shut, staff were told to work at home. Many businesses were told that, businesses were told that if you could only maintain 30% of your working staff unless you were essential services. So a lot of things were stopped during that period of time, except for essential government services. So this was the other situation, that of the migrant workers, causing a wave of COVID cases. And because, as you can see, the migrant workers live in very close communities in dormitories, there are about 300,000 of them. Some of these dormitories have over 5,000 residents, and they are fairly self-contained. So when the outbreak started to take root in the dormitories, it spread like wildfire. So with that, we started to deal with close to thousands of cases, over 1,000 cases a day, being tested at all the hospitals at our newly built up National Center for Infectious Disease. But very soon, we realized that many of the cases were not actually sick. They were very mildly sick, in fact. So we started to expand facilities, or immediately started building facilities to hold the very well patients. We started to hold some patients on site at the dormitories, where we catered space for isolation, for quarantine, and then for the ones who had mild symptoms of just fever or simple acute respiratory infections, they would be monitored in this huge place, which was a converted exhibition hall. There were multiple such places where the patients were all being housed. And then they were monitored daily by medical staff, taking vital signs as well as pulse oximetry readings. So as patients recovered, they were moved to a recovery facility where they would stay in isolation until we were sure that these patients were no longer infectious. And this is an example of the government quarantine center. This is one of the MOH staff teaching some of the government workers how to wear their PPEs properly, as well as how to check for the mask fit. This is what it looks like. As you can see, this is the initial screening, temperature screening and declaration tent, which is at the front of the facility. And patients would stay in these holiday chalets that have been converted into isolation spaces. You can see there's a table here, and the little table down here is actually for people to leave newspapers. Those who are in isolation could actually order from a Grab driver. Grab is something like Uber or Uber Eats. So the food will be left there, and then they will come out and collect it. So you are stuck there for 14 days in isolation and quarantine upon return to Singapore, or being positive contact of a COVID patient. So over time, the business of isolation and quarantine had also expanded very significantly. So many hotels had also started to take on these duties, because once the borders were locked down, there was very little travel and very few tourists coming in. So the hotels were largely empty and actually suffering quite badly. So we turned many of these hotels, or the government negotiated with the hotels, and some of them took up the offer to run quarantine facilities in these very nice spaces. So after the lockdown, then we started to look at cautiously opening up the country, as well as starting to develop risk strategies to test, contact trace, mitigate clusters of outbreaks. At the same time, we were also very concerned in terms of how we could open up the economy safely while maintaining the ability to prevent new outbreaks. So this was what Thomas Puyol described as the dance. This whole very complex technical testing of various ways of opening up the economy to allow for more activities, to allow businesses to resume, work to resume, school to resume safely. So what happened was that over time we developed multiple pronged strategies. One was building up very aggressively the ability to swab more and more patients on a daily basis. We moved from being able to swab 8,000 patients to 40,000 patients a day. There was a lot of work in the background, procuring test kits, surgical masks, to ensure that everybody had masks. We had a lot of organizations starting to make reusable masks as well. And the general practitioners also were pulled in to become public health preparedness clinics. So over 900 clinics, right, had volunteered to be trained previously because of the influenza pandemic. So they were already trained and they were already prepared from the perspective of being issued PPEs, test kits, and being able to work with the government to do subsidized testing for patients who had acute respiratory infections. So the other part of the equation was actually a tiered response. So we targeted the elderly, the ones living in nursing homes and those in close quarters, to try to protect them from the COVID-19 infections. So by messaging to the elderly to stay home, to wear masks, this was largely effective in preventing them from gathering in public spaces and from mixing around. Beyond that, the other key thing that we did was actually rapid mitigation, which was actually to scale up our contact tracing capability with the Ministry of Health. This was centralized with the use of technology, with the use of interagency support between different ministries, such as the Ministry of Health, Ministry of Home Affairs, and also various statutory boards which contributed manpower for the efforts.
Outbreak contact tracing is essential to curb the spread of the disease. Contact tracing identifies individuals who may have been exposed to people confirmed to have the virus. These individuals are monitored closely and may be quarantined so that they can be treated early if they develop the disease and not expose others to it. This is how Singapore, from its health institutions to government agencies, carries out contact tracing for COVID-19 cases. When a patient is diagnosed with COVID-19, the hospital will interview him to map out a full history of his movements over the last 14 days prior to the onset of his symptoms and until he is diagnosed and isolated. This time frame is chosen to adequately cover the incubation period of the virus, which typically lasts 5 to 7 days. This activity map is a detailed timetable documenting where the patient has been, what he has done, and who he has made contact with. For a patient who came from another country, or what is known as an imported case, this activity mapping starts from the time he boarded the flight to Singapore. The hospital then submits this activity map to the Ministry of Health, which oversees the entire contact tracing operation. The Ministry of Health's contact tracing team comprises staff with expertise in communicable diseases and epidemiology, as well as volunteers from the ministry's various departments and statutory boards. The team aims to completely chart a patient's activity map within 24 hours of his COVID-19 diagnosis. Contact tracers make calls to verify the patient's activity map with third parties, such as family and friends, airlines, and transport companies. During these calls, they also obtain more details and may contact the patient or his next of kin to fill in any gaps in information. The team identifies a list of the patient's close contacts who would be at risk of infection. Close contacts are people who have prolonged physical contact with the patient or live in the same place. They are typically family members, close colleagues, or travel companions. They also include those who have spent at least 30 minutes within 2 meters of the infected person. The ministry will contact these close contacts and check if they are feeling unwell. Close contacts who have coronavirus symptoms are treated as suspect cases. The suspect cases are hospitalized in isolation wards and tested for the virus. Close contacts who are well but deemed at risk of infection will be served a notice of quarantine by a health ministry officer, together with a certain security officer. They are given the choice of staying at home or going to a government quarantine facility for 14 days from their last contact with the patient. Government quarantine facilities across the island at places such as the SAF Changi Chalet, Outward Bound Singapore, and university hostels can house around 2,000 people. More than 200 Certis security officers are deployed daily to these facilities. Their tasks include settling people into the quarantine facilities, patrolling the area, and facilitating check-in and check-out procedures. Contacts under home quarantine must stay in a room and use a toilet that is not shared with anyone else. If a close contact can't be reached or his identity is not known, the Ministry of Health will tap on the Singapore Police Force for help in tracing the person. Daily conferences allow both sides to exchange updates and collaborate. Overseen by a command center, the police's contact tracers are split into 3 teams: an analysis team, an interview team, and a field team. The analysis team gathers all the data surrounding COVID-19 cases in Singapore and identifies possible links between cases. Analytic tools such as word clouds pick out common keywords from the activity logs of different patients. Possible links are flagged as hypotheses to the interview team, which then conducts thorough interviews with patients and close contacts. Information gathered will prove or disprove any hypothesis. Meanwhile, the field team combs the streets to track down uncontactable or unidentified close contacts. The team trawls through closed-circuit television footage and conducts ground inquiries for clues. Such cooperation between the Health Ministry and police has led to important discoveries. Among them is the unearthing of a link between the cluster at Grace Assembly of God Church and another cluster at the Life Church and Missions. Police analysts cross-referenced attendee lists and, through a Singapore-made serological test, detected past infections in recovered patients. This uncovered a chain of infections linking the 2 church clusters to a Chinese New Year gathering in Mei Huan Drive. Extensive groundwork has also paid off in identifying and locating close contacts of patients. In one instance, police had to track down an unidentified passenger of K64, a 50-year-old taxi driver. They knew only 3 things: the type of taxi, the passenger's attire, a white top and black pants, and the passenger's general drop-off location, somewhere along Chai Chee Road. Officers had to visit at least 5 housing blocks in the area and sieve through more than 3 hours of CCTV footage from over 40 cameras. After identifying the passenger's block and floor, they knocked on many doors before finally pinpointing the passenger in his home. A newly developed smartphone app, dubbed Trace Together, also allows local authorities to speed up the contact tracing process. Developed by the Government Technology Agency, or GovTech, and the Ministry of Health, the app uses wireless Bluetooth technology to detect other users in close proximity. Logs of such encounters are stored locally on each user's phone and can be submitted to official contact tracers when necessary. This is useful when infected patients do not know everyone whom they have crossed paths with and allows for easier identification of potential cases. Meanwhile, the Singapore Civil Defence Force, or SCDF, responds to COVID-19 suspect cases via calls from the public, general practitioners, and polyclinics. Operators at the SCDF Operations Centre check on the symptoms and travel history of suspect cases before paramedics take them to the hospital. Under Singapore's DORSCON orange status, SCDF officers don full personal protective equipment when responding to all medical cases. This extensive process of contact tracing and frequent cross-agency cooperation have helped Singapore to quickly identify potential COVID-19 cases and limit the further spread of the disease.
So another measure that we took on besides contact tracing is the communication of all the evolving measures. I think that was a very key part of the strategy that we had, because with this whole idea of evolving measures, gradual opening up, things kept changing, and it could be very confusing in terms of what was allowed, what was not allowed, and what were the new procedures that we were piloting to allow economy to open up. So the government had actually gone through multiple mediums of communication, from the news on TV, the print, new media, websites, and we've even gone to use WhatsApp as well as Telegram. So I think for us, this is the first time where the government had actually created a channel on WhatsApp as well as on Telegram to communicate the measures that we were doing. And I think over time, some of this has even evolved to info chat bots on Telegram, for example, that interacted when people wanted to ask more questions about some of the COVID-19 measures. Another new initiative that we piloted was this idea of wastewater COVID-19 testing. So what you can see on the right, is an automatic sampler. This would actually collect wastewater samples on a daily basis. I think it's a couple of times a day. So this would actually sample the sewage, and this could actually allow an entire block to be monitored for COVID-19 virus shedding. So what happens is that the staff would install these samplers inside a manhole, and it would sample the sewage. And what happens is that these samples will be taken up regularly for testing to see a trend of whether there was a rise in or detection of active COVID-19 virus particles. So this would allow the National Environment Agency as well as Ministry of Health understand if there was a rise of COVID-19 cases in various strategic areas, places where there are concerns about large numbers of people. So this was installed in various places like the dormitories, prisons, for example, where people live in very close quarters. In addition to be able to manage the large numbers of cases that were being transported to medical facilities for testing, for isolation, for triage, as well as for admissions, the government had also started to enlist the ride-sharing drivers to take on these duties to be cross-trained as COVID-19 transporters. So this is the Singapore Civil Defence Force, which is the EMS service, providing training and briefing for the ride-sharing drivers to be able to be mask fitted and to be able to safely run patient transporter as well as do disinfection after transporting each case. So the private ambulances, of course, got into the action. This was a dormitory during the peak of the outbreak. Actually, the photos are taken by myself. And this was an endless stream of ambulances, over 100 a day at some of the dormitories, where the people were being tested and the ones who were positive were being sent to the hospitals or the community facilities. The picture here shows a whole group of people who have all tested positive and they're all waiting for transport during the peak of the pandemic. Technology also played a very large part for us. Over the last few years, we've started a government agency that had its own skunk works type of team where they would be able to rapidly iterate and create a mobile app using what the tech people call agile methodology. So the idea is to quickly build a minimally viable product through experimentation and testing and working with the client or the operators who need a particular technology, and then they would build incrementally in what they call sprints over like a couple of weeks, showing the client what they've built, and then pivoting and shifting it until they get a minimally viable product. So this allowed us to rapidly build up certain mobile applications that would allow contact tracing to occur very quickly. So some of this I'll go through as well. We started to use QR codes as well as a check-in system so that people could register that they've been to a place. And after a while, this became a standard where if you were going into a shopping center, going to a hospital, you would have to do a check-in. And if, for example, there was a COVID-19 case that had gone through exactly the same place, this would be fired off as a short message, SMS, to let people know that, for example, they've become a close contact. We've also created a contact tracing app called the Trace Together app, and that would allow Bluetooth signals between phones that are nearby to exchange signals and information. The information stays on the phone until there is activation of a positive COVID-19 case. So as you can see, this is actually the grocery store, and then this is the QR code to allow people to scan and to be able to quickly do a check-in. So trace together, I think as mentioned in the short video that you saw, the idea is to allow Bluetooth signals to be exchanged. It stays on the phone securely and is encrypted. So it's only when one party is exposed that they will send this out to try to inform the other parties to let them know that they were actually close to somebody who had actually been tested positive for COVID-19. Over time, this has evolved because we recognize that some of the elderly may not be so familiar with downloading mobile applications. So they created a trace together token that gives off a Bluetooth signal. This thing will last for months. I think eventually it will have to be replaced. But at this point in time, this is being issued to the elderly and also people who may not carry smartphones. Of course, Singapore being Singapore, I think some of these interesting things were being tried. This was a robot dog ambassador that would encourage social distancing. Using artificial intelligence, the dog would actually be able to count the number of people that are gathered very close together, and it would actually go around the park and broadcast a message to tell groups of people who are gathering to actually maintain social distancing. So in terms of the EMS, as early as 7th of February, we've actually scaled up to full PPEs. And you can see in Singapore, the temperature is actually up to 34, 35 degrees during the day, sometimes even warmer than that. And wearing full PPEs with the gown, N95 mask and goggles is not an easy thing to do. The other thing that we did was also disinfection. In the old days, you would be wiping down manually using alcohol wipes. But we've actually started to use this misting systems that actually are typically hydrogen peroxide based. And what happens is that after each case of conveyance, we would put these devices into the ambulances, shut the doors, and allow the misting to occur. This would allow the ambulance to be thoroughly disinfected, and the equipment are actually rated to be safe to be disinfected as well. So this is the new version, which is called SterilMist. It's also a hydrogen peroxide based product, and essentially what we do is that after every conveyance of a COVID-19 case, the ambulance is sprayed down, doors are closed for the hydrogen peroxide to work its magic. And in the old system, it took about 30 minutes. But in the new system, this apparently is more effective and rated to be to work after about 15 minutes of disinfection. So of course, the call center also has a role to play. And in fact, during the pandemic, at the peak, right, we were getting a lot more calls from anxious citizens about COVID-19. On the 19th of June, PPE attire was actually stepped down. As you can see, this was actually myself. I had attended to a cardiac arrest case because I was summoned as a citizen through a mobile app called the My Responder app. So this is sort of like the Good Sam app, which is quite common in Australia. So My Responder is a mobile app that was built locally by myself with the help of GovTech, which is our government technology agency. We also have an ongoing trial with Liddell to have a CPR card, which allows the responders to know the depth and the rate of their CPR. So this is the group of paramedics and firefighters actually providing cardiac arrest response, okay? And this is actually in the actual house. So I came in as the first responder, followed by a motorcyclist, and then followed by a fire crew and the ambulance crew. This is the ambulance crew after the response in their fire gear. So this is just a little bit of data which we were monitoring with COVID as well as cardiac arrest over the first few months of the pandemic. As you can see, the bystander CPR rates are actually not too bad. People continue to help do first response CPR or chest compressions. Telephone assisted CPR help to keep the numbers up as well. And then even the AD use is actually quite decent. So during the last few months of pandemic, I think we've actually even had a general election on the 10th of July, which was safely conducted. We did not have a spike of COVID-19 cases, 2 weeks after that. We've also started to move from this phase one of post-lockdown to a transitional phase, which is what we call the safe transition, and we are trying to move towards eventually a phase 3, which we call safe nation. The idea is to move towards a new normal where we are able to bring the economy back online and keep safe without having more outbreaks occurring. So a lot of the strategy rests on protecting the elderly, protecting the vulnerable, as well as continued mask wearing and social distancing. So very sadly, air travel is, of course, highly restricted at this point in time. So the Singapore Airlines, of course, is our national carrier of pride and joy, but it's also had to pivot quite significantly because of COVID-19. As you can see, this is a picture of the SIA cabin crew who were redeployed. Some of them were working in the hospitals with us at Tan Tock Seng as well as many other hospitals. And of course, they are fantastic ambassadors, given that they're really good at customer service. The Singapore Airlines Training Center has also become a place which is open to the public for experience tours, flight simulators tours, food tours, so on and so forth. And there are even people who had signed up for dining experience on the grounded planes. So other things, right, including the resumption of air travel is starting to occur a little gradually. We have a way of, we've been classifying different countries in terms of their COVID-19 numbers to be able to come up with a strategy to allow a resumption of air travel, some of it including essential businesses or even a travel bubble, which we're trying to start off with Hong Kong, where both sides allow people to move back and forth without having to do a quarantine on arrival. So some of the other measures that I think are starting to occur includes the whole encouragement of tourism while being safe. So that's not easy to do. This includes things like a flight to nowhere. This was being picked up by the New York Times. We also had some gradual resumption of many other activities, including weddings, opening up of cinemas, social activities, and religious activities. So all in stages and phases. Right now, I think for public gathering and going to eat out at restaurants, right, you're not allowed to, or at least we only restrict this to 5 per table at the moment, so no larger than that. As you know, a lot of Chinese food, Chinese cuisine, people tend to gather in large groups, right, 10 to a table. So some of the resumption of nightlife also comes with, mask wearing until people are, stop for food. But after that, they mask up again. So one other feature of how we are enforcing a lot of the mask wearing and social distancing is that some of the government ministries whose work have shifted very significantly. Some of the staff have been redeployed. For example, the people working in tourism have actually been redeployed as social distancing ambassadors. So this was picked up by the Los Angeles Times about how people have been redesignated to work as safe distancing ambassadors. So they wear these very bright red shirts to let you know that that's their work, and then they remind people to stay safe, to not gather or mix around in large groups. So this is another picture of what it looks like, and they wear these badges that very prominently say safe distancing ambassadors. Of course, it's not without its own challenges, because everyone having to live under these restrictions are, going stir crazy. So the restrictions on the large gathering of people still stay in place. We also have a restriction on alcohol that after 10:30, outlets are not supposed to serve alcohol. So we've had people come up with very creative ideas of even serving alcohol disguised in teacups, and this was caught by one of the safe distancing ambassadors, who noticed that what would have been a hot cup of tea had a lot of moisture gathering there. So that led them to check and realize that people were still pouring out beers in teacups at 11 or 12 midnight. So another part which is starting to open up is this idea of allowing the resumption of conferences and meetings, large meetings. Currently, we have allowed up to some pilots of 250 people. However, in the event, they are splitting people into groups of about 50 and cohorting them in smaller numbers as well. So while maintaining some of the safe distancing, and the event needs to have enough space to accommodate all the people and allow them to space out. So these are, I think, a look at some of the measures that we've taken while gradually opening up the economy. So I think the next steps for us, right, is really to look at setting up or ensuring that we have a proper cold chain, as well as the mass vaccination strategy. At the same time, we have our Health Sciences Authority looking at expedited approval for the newly FDA approved vaccines, as well as what is being approved in Europe. Local partnerships in terms of developing our own vaccine, as well as to look at a multi-source vaccination strategy to be able to buy from different providers. We are moving into this idea of a new normal of phase 3, whereby we are able to open up the economy, but at the same time, we know that with the opening up of the economy and resumption of some air travel, we will expect to import more cases of COVID-19. And with that, I think what we're trying to do to ensure that cases of COVID-19 can be controlled is that we are trying to increase the adoption of this Trace Together app for rapid contact tracing, ensure that there's good compliance with mask wearing, and also to continue to build up testing capability as well as the turnaround time, so that people can be rapidly tested cheaply, and then tested in larger numbers to ensure that any outbreak is picked up really fast, as well as the ability to isolate, quarantine, and to mitigate the outbreak as soon as it occurs. So right now, we are still in this long phase of dancing our way to when the vaccine is widely available. I think the key lessons for us, looking at, today is when I'm recording, was the news from the BBC about the first person in the UK receiving the Pfizer jab. For us, what we've been doing is that we've taken a whole of system approach in managing COVID-19 by coordinating on an interagency level. And as mentioned, we've been building up the detection and mitigation capability, swab testing, being more aggressive in testing, and also shortening the turnaround times. And this paired together with rapid contact tracing allows us to contain the outbreak whenever it occurs. Risk tiering is also another key strategy, as mentioned, that we want to protect the vulnerable groups so that we can detect early, treat early, manage them so that cases stay out of the hospital and the ICU preferably. And so far, this has been successful in the last 2 months. Communication to the public, giving people information and helping to build trust among the citizens with the government. So that way people would listen when the government advises people that new measures need to be taken. And lastly, this whole dancing, right, or piloting and pivoting new initiatives to allow us to combat the disease better, and also to cautiously pilot new initiatives to open up the economy safely. So I think these are a summary of what we've done in the last 10, 11 months of battling COVID-19. So this is all I have to present for this webinar, and I'll be happy to take any questions that you have. If you've missed the live segment of the Q&A, feel free to just either look me up on LinkedIn, or you can write to me at my email address. Thank you very much.
Great presentation, as always. Really informative, and lots of amazing stuff, of course, conducted by your service in Singapore. We've got a few questions from our audience today. I'd like to kick off. One of the challenges we're facing in Australia and New Zealand, YY, is PPE fatigue. Paramedics have been using PPE extensively now for a long time, and complacency sets in. Just wondered, I recognize that you're starting to reduce the amount of PPE that you're using now, but how did you get to that decision, and how did you manage PPE fatigue in the interim?
Right. I don't think there's an easy answer to the question, because I'm still doing shifts at the ER, and I predominantly just do shifts in the resus room. So every shift I'm in full PPE still. Singapore's weather is, of course, a significant challenge, because we are typically about 25 to 35 degrees outdoors. And I work in the ER, so it's mostly quite cool, about 20 degrees. But even then, right, after about 4 hours, we're soaked right through, being in PPE for about 4 hours before we take like a coffee or a lunch break. I think for EMS, I guess it depends on how busy. As a urban system, our guys are doing maybe about 8 calls in a 12-hour shift during daytimes, and during night times it's about maybe 5 calls. So I think it's still fairly tolerable from that perspective, especially for the night calls. For the day calls, in some of the downtown and the areas where there's a lot of elderly, you could be running consecutive calls non-stop. Like maybe like 3-4 calls, they are back to back, or you do a proceed call, meaning that you go to the next call before you've actually reach back to your station. We've actually started to get the people to dress down. So since the start of the pandemic, right, we used to wear more formal attire with the nice shiny buttons and ranks and all that. But we've actually switched everybody to just t-shirts and the dress pants. So I think that's helped a little bit with the heat. So they've gone down to simple cotton shirts, which is a little bit better from managing heat from the perspective. Anecdotally, I think sometimes our guys are taking a little bit more time between each of the calls, and it has helped a little bit with the fact that our ambulance fleet has been on a planned increase. So from the time I started in 2012, right, we were running about 36 ambulances during the day and 30 at night. Now we're up to 80 ambulances in 2020. So I think from a relative perspective, right, the paramedics feel that life is a lot better than it used to be. So I think our guys maybe complain a bit less because of that.
Thanks, my wife. I've got a question from Louise, and she asks if aerobic fitness is one of the most effective heat mitigation strategies. Does that mean we should begin preparing ourselves well before the heat wave season, which obviously Australia and New Zealand are entering into?
Yeah, I think for if you're talking about responders and healthcare workers, I assume. Yeah, I mean, yeah, because I think in military, heat tolerance is also military as well as police and firefighting. Heat tolerance is of course a key issue. We've actually had quite a few years of experience working with our medical response force in the military previously, and these guys are the ones who wear MOP 4 suits or the biochemical suits. And how they prepared, right, was that they would get these guys to wear the suits minus the chemical mask, and they would actually walk around in the suits literally for I think 8-10 hours a day. And they would make them shower, I think, 2 or 3 times a day, because otherwise you run into problems with with sweat, perspiration, and skin issues. But we've actually done some internal testing, right, where the guys who were used to wearing the MOD 4 suits, when we put them through fitness tests, even though many of them actually did not start as being very fit, but the heat acclimatization had actually made them superior in operational fitness compared to other soldiers. We actually had them run the test against soldiers that were actually much more fit by the conventional fitness testings that we have. We have this thing called the Individual Fitness Proficiency Test. So when they compared against people who routinely had goal results, like they could run 2.4 kilometers in like 10 or 9 minutes, these guys wearing the MOD 4 suit and acclimatized, when they were asked to do certain tasks, right? After I think about 3 to 4 months of acclimatization, they were routinely doing the task much better than the guys who were much more fit compared to them.
Very interesting.
Yeah.
Here in New Zealand, we've just turned on Bluetooth tracing, and I know,
right.
And I know obviously that's a consideration for Australia at some point too. And I see in your strategy to get to level 3 or phase 3, it's an increase in the amount of Bluetooth uptake.
Yep.
How do you convince populations to do that, and how do you get over the fear of privacy issues?
Yeah, so I think this has been emphasized a lot of times in terms of how we manage privacy, because one of the things that we do in the design of the Trace Together app is that the data is actually stored locally and is encrypted. There's a certain amount of anonymization, and it does not collect GPS locations. So if you're on the Trace Together app, your phone exchanges a Bluetooth signal with another phone. It doesn't really say where you are, in case you have that privacy concern that I don't want you to know where I went. But the fact is that if you exchange a signal and that person was tested positive, what happens is that Ministry of Health will decode that signal of the person who's positive and their Trace Together app recordings, and this will identify phones which they will send messages to tell people that they need to come in because they are now contacts of someone who's positive. So it's only at that point where this happens and the information is used. Otherwise, no other ministry, so the police, any other agency has no access to this data except for the Ministry of Health. So I think we do as much as we can to maintain this sense of trust about how the data is going to be used and then how restricted the use cases are. And I think there's a guarantee that we are not going down a slippery slope of using this to monitor citizens for any other reasons. I think that has been communicated multiple times about how it's going to be used. Yeah.
That's great. Just thinking about the impact, the changes, different thinking going forward, YY. I've noticed with a number of the services in Australia and New Zealand is that the traditional business continuity planning, which used to sit outside of emergency management, is now being moved across. Just wondered if similar things were happening in Singapore or different approaches to planning for future pandemics.
Right. I mean, currently we are still talking about the current pandemic, and the framework that we do, right, is that we have a system of, we have the political leadership, which actually chairs the ministerial task force. So they look at the political considerations on a national level, but the executive group is run by the permanent secretaries of all the ministries. So my permanent secretary for the Ministry of Home Affairs is the chair of this group called the Homeland Crisis Executive Group. So they, as a committee, would work on the inter-ministry level between all the government agency, the statutory boards that provide some of the associated functions. And this helps us coordinate all the responses. So everything that you need from social welfare, communication, education, manpower, government emergency services, security, safety, health. So all of this is covered, including water resources, for example, if needed. So this helps, a lot in terms of setting the overall strategic and operational direction for how we want to manage COVID-19. So you should not get a situation where some ministry says, no, we have no clue what's going on. So when we first started the COVID-19 response, right, the ministries were meeting twice a week. So the permanent secretaries were meeting twice a week just to discuss all the key issues. Communication comes out extremely strongly because we recognize that the citizens do want to be empowered with information so that they can do the right thing. And I think that has helped significantly, because even communicating within the ministry is already a challenge. And imagine going out to 5.6 million people to try to ensure everybody has the same message and behaves accordingly. So that's not easy even now.
No. And of course, the most important question I should ask is, when will we see a bubble between Singapore and Australia and New Zealand?
Yeah. I am quite hopeful that this can happen. I think Singapore has already opened unilaterally to Australia and New Zealand from what I remember looking at. So I guess, whenever Australia feels ready to reciprocate, right? I think we can do a travel bubble hopefully soon.
Yeah, agreed. Excellent. Well, I think we have to wrap it up there as we are running out of time. Again, Wai, thank you so much for sharing your insights with us and the experience in Singapore. Now, at our next conference, which of course I hope you attend, we will expect to see you on the dance floor, having practiced the dance for so many months. So we look forward to that.
Yep.
But again, thank you, Wai. Take care. Good luck with progress over there. And thank you again for sharing with us. We really appreciate it.
Oh, you're welcome. It's been my pleasure.
Excellent.
Thank you.
Thank you for attending Singapore's response to COVID-19 webinar. Join us for our next webinar on the 28th of January for 1 year on from the Vakari White Island volcano eruption with Dr. Tony Smith. Follow us on social media to keep up to date on Twitter at the Council of AM1, LinkedIn and Facebook, Council of Ambulance Authorities Australasia. Have a safe and happy holiday season, and we look forward to seeing you again next year.